Good afternoon, everyone. A warm Sunday afternoon greeting to all. My name is Ivan Walks, and welcome to another Black Health Trust. I'd like to turn us over to Dr. Maxey, our founder. Good afternoon, sir.
Thank you, Dr. Walks, and welcome. And Dr. Hines, Dr. Jocelyn Hines. Since last week, we had a Dr. Latanya Hines, and we know our other esteemed colleague is off in Sweden visiting her daughter and her family. We're very pleased to have a very exciting speaker for today. And I'm going to introduce her in just a moment, but I want to take executive privilege, and I see that one of my longtime cousins is on, Attorney Anthony Maxey. Glad you're here. Haven't talked to him for a while. Today's topic is so relevant, especially as many of us are entering into being seniors. I think being a senior means you're 65 years old. I'll be there in about 10 more years. And we do have concerns about our health, our livelihood, and we also have the potential risk of Alzheimer's and dementia and other things that happen. So it's so important to make sure that your seniors in your family, as well as you, are safe and well cared for. And we all know that many of us cannot necessarily always go out to see a healthcare provider in person. And many times we have to have physical therapy at home. We have to have nurses come home, physicians come to our house. And our speaker today is Miss Mary Alice Johnson. And she is a wonderful lady that I met at the invitation of Dr. Richard Williams some months ago. And I've had a chance to interact with her on several occasions, but let me introduce her formally. She was born and raised in Detroit, Michigan. She's a graduate of New York University with a BA in liberal arts and an associate's degree in marketing. And because of her experience in life, she moved into care of seniors. She is also a former professional model with both the Ford Model Company and Wilhelmina Models. She spent time in Japan, in South Africa, so she's had living abroad as part of her foundation. She also worked as a caregiver and had direct contact with the care of seniors and patients. And she has great empathy and a great personality. And I'm very happy to bring us knowledge about all these areas of concerns of growing older, how we take care of not only ourselves, but our relatives and our safety. Ms. Mary Alice Johnson, welcome to Black Health Trust.
Thank you so much for that very, very humbling introduction, Dr. Maxey. I really appreciate it. I'm happy to be here. I'm honored to be here, and I just want to be helpful. As you said, it is a space and a topic that is relevant and increasingly so because we are aging, and the aging population is growing at such a tremendous rate, excuse me, and the family caregivers, the individuals themselves, seniors, and resources are not quite keeping up with that pace or are getting burned out or a combination of the two. So we are in healthcare trying to address it as best we can while we move education and resource development forward. So I'm really, really happy to be here.
Thank you.
You're welcome.
The floor is yours.
Well, Dr. Maxey introduced me and gave you a little bit of my background. I want to just make one quick clarification. I've never worked as a caregiver. I've worked in the caregiving business as a care consultant and the director of business development for caregiving agencies. But I think, at some point or another, we've all had some experience with caring for a loved one or a friend who was infirm and I certainly had that experience with a loved one, and I think it ended up being a foreshadowing of my being in healthcare. So about 30 years ago, 25, 30 years ago, I had the pleasure and the unexpected occasion to take care of my great aunt. I was visiting her and she had a stroke, and I had to get her to the hospital and quickly learned that she had a brainstem stroke and was not going to be able to walk anymore. So they diagnosed at the time, and that she couldn't live alone anymore. And suddenly you're thinking about things that you just never thought about. She was 97 years old, a very vibrant, intelligent spitfire of a woman. And I just never imagined her being in this situation. So together we had to talk and think about what resources were in place, if any, and what she wanted to do. I was living in New York and she was living here in California. So that presented a specific set of dynamics that were going to be difficult to navigate. I had nowhere to turn, didn't know the first thing about providing in-home care or what it was. And the resources at the hospital did give me some basic information, maybe a brochure or two about care, but care at that time even was cost prohibitive for her and for myself to manage my home in New York and here. So the only resource left was nursing home. And of course, seniors want to live out their lives in their own home, 9 times out of 10. It's been my experience, and doctors have told me that as well. So that personal experience was one that did fare well for the most part. I found her a great nursing home, and I visited very often twice a month, coming from New York. I was able to do that at that time. And she was there for about a year. I was able to take her traveling to see my grandmother, who was her sister. And she did make her transition there. Again, when all of that happened, I had to get her house put into a living trust. So that required finding the right resources, just things that you're maybe not thinking about ahead of time. So it is important to think about these things ahead of time and have these conversations that many of us, particularly culturally in the Black American culture, in my experience, are not comfortable having. With the elders in our family are not comfortable talking about what happens when they make their transition. So I can't underscore that enough. These conversations need to be had and plans put in place so that we don't, and I'm just going to be frank, leave a mess for families to clean up. So going back to how we start with putting a plan in place, having the conversations and coming to opportunities like this where topics are discussed, so we educate ourselves and educate the community on what services are available when a need arises. So I started in caregiving, in the caregiving space, and I learned in my research and preparing for my role to be effective in my role that the Department of Health and Human Services says that 70% of Americans are going to need a caregiver, and for an average of 3 years.
Wow.
I was surprised, but not shocked, because remember, I had been there some years before, faced with that very decision to make. So, but what I learned quickly is that the patients I was talking with in the hospital in my role as a care consultant or director of business development, patients were not thinking about that. Here I am again. Most people are not aware that these needs are going to arise or have a plan in place when these needs do arise. So you want to educate the community, and this is a platform, and we create other platforms in which to do that. And you want to talk about what you want to do if you are not able to live at home alone, or if you are able to live at home and have a caregiver in. So what options do you have? So in-home care is when you have a caregiver come into your home to provide you with the activities of daily living. You have been diagnosed as someone who needs support with the activities of daily living. You're either bedbound or need assistance. And those activities of daily living are toileting, bathing, grooming, meal preparation, even transportation, medication reminders. You're also going to need someone to maybe help you with paying your bills, sitting down and making phone calls for you, putting other resources in place to make sure that you have what you need at home to thrive. And it's designed to have a certified home care aide, and that is someone who has taken the tests through the state of California. I'm just going to speak to California. And it's a 5-hour test to qualify you to be a caregiver. You don't have to be a nurse. You just have to take this certification through the California state, and you can be a caregiver. And then hopefully the agency that you're working for, which I do highly recommend, and I'll talk about that in a minute. Hopefully that agency is providing you further training on transferring, on safe transferring, on how do you prepare meals, how to interact with the individual, how to be a companion, because your work is both providing them with the physical needs, helping them walk, assistance with walking, transferring, like we said, toileting, bathing, grooming, and also being a companion to help keep their spirits up. What do they like to do? How can you engage with them that keeps them socially active so that you are also maintaining healthy brain activity? Because once a senior starts to decline, the likelihood for cognitive impairment increases due to lack of socialization and isolation. And so there are a myriad of conditions and states that arise that we all need education on so that we're prepared to handle when they arise. So I want to just pause there for a moment and see if anyone has any questions before I go on.
Yeah, let me ask you a brief question as we start. You mentioned the word, most of our people are lay people. What do you mean by transferring?
Yes, safe transferring means helping the individual move safely from the bed to the walker, from the walker to the wheelchair, safely from the bed to the walker to the toilet, safely down onto the toilet, safely up from the toilet. And this is something that I believe should be done in person, hands-on training. And that's something that the agency that I worked for did. We brought the caregivers in. Once we would hire someone that had their certification, we'd come bring them in for actual hands-on training to make sure that we're sending out a caregiver who is qualified, that we have seen that they can actually do the transferring. The state of California does provide for family members to be paid to be caregivers, and you can do that through the in-home supportive services agency. And that is something that's federally mandated as well, provided for. But here in California, again, the in-home supportive services can talk with family members about a family member being a paid caregiver, or that's also an agency that helps families who have less resources financially and less financial means. So they will cover a portion of a day, not 24-hour care. I think it's anywhere from 4 to 6 hours. It may be up to 8 hours, but they will cover that. But
so is this nationally, since the audience is all over the country, is this nationally available or just in California?
It's nationally available, that the federal government provides money to pay family members to be a caregiver for their loved one in the home, for a homebound family member, yes.
Dr. Walks and Dr. Hines?
First of all, thank you so much for bringing us this very important topic and bringing us this aspect of it, opening the conversation, having folks understand what the specific needs are. As you mentioned, Ms. Johnson, that as folks begin to show some isolation and maybe cognitive decline, that is a concern and ways to address that. I just wanted to know if, as folks are being trained, they're being trained also to recognize signs of depression, because that can be a factor as folks age and as folks are isolated.
Absolutely. And we've seen such an increase in the senior. So actually, I should back up for a moment. I'm the director of marketing at Epic Home Health, which is different from caregiving. So I'm going to explain that difference as well. But just to address your immediate question, we have seen such an increase in depression and anxiety and even suicide attempts with seniors. Definitely increased with COVID because they were so isolated in the senior living communities, kind of locked in their rooms for protection. But the result of that was an increase in anxiety and depression, and just the isolation was overwhelming. So yes, the caregivers, because they are going to hopefully be trained by the agency, and I can't underscore that enough because it goes to the difference between hiring someone who's a family friend that took care of your neighbor down the street, or hiring a qualified, trained, vetted caregiver who is certified by the state of California, who's licensed and who's bonded and registered with the Department of Social Services. So yes, that caregiver will get some training on cognitive impairment signs and symptoms to look for, so that that caregiver can notify the family member and the agency, so that that communication process can be done. And the caregiver is very instrumental because they're boots on the ground. They are the ones that are there with that loved one most of the time, while family members are at work, of course, and the doctor is, not there. So they communicate with the doctor to update them and then update the care plan, because that is what a caregiver is implementing. A care plan that's been created by a care manager at a caregiving agency. That process begins that way. So we get a referral to a patient, we go out and do an assessment. The care manager who's doing the assessment creates a care plan, and that care plan is implemented by a caregiver who is identified as the best fit caregiver for that individual based on what their likes and dislikes are, what kind of activities the individual wants to engage in. Does the caregiver have that characteristic and part of that and those activities as part of their resume, or interests as part of their resume? So it's all about making sure that the caregiver is the right person for that individual. So we're giving personalized care. That's what you should expect, and that's what you should be asking for when you are vetting the caregiving agency to come and care for your loved one.
Thank
Dr.
you.
Hines.
Thank you again, Ms. Johnson, for this topic too. I also have been in the caregiving space, and one of the things that you kind of touched on was about the timing and amount of support. Lots of times I have found, at least in the beginning, there's often a disconnect between what people think is the amount of support, the time and the amount of support that they're going to be able to get versus what oftentimes you're actually eligible for. And I just wanted to see if you could kind of speak to some of those kinds of misconceptions about what caregiving resources can do versus not do, right? Because sometimes no one's going to care for your person like you would, but it can be very jarring, right? To really understand, bathing and like it's not going to happen the way you would do it necessarily.
Yes, I think what you're speaking to, is it Dr. Hines? Dr. Hines?
Yes.
Yes, Dr. Hines. Thank you for your question. And thank you, Dr. Was it Wilkes? Walks?
Walks.
Yes. Caregiving is paid out of pocket, Dr. Hines. It is not something that the caregiving on a 24/7 basis, which is what most patients need, is paid for out of pocket. You have to qualify for the IHSS services that are paid for by the state of California or federally. So that means you have to have demonstrated a financial need. If you don't demonstrate that financial need, then it is up to you and your family to create a path toward being able to afford it. What I've seen often when people say, oh, it's so expensive, the average rate right now is about $38 to $40 an hour for a caregiver from an agency. Many people still find that difficult to meet. So I've seen family members come together. For example, the adult children will pool their resources together to try to get care for mom and dad. Or also long-term care insurance is accepted. So again, with a private caregiver from an agency in your home, you have to pay out of pocket for that service. The government, Medicare still is not paying for that in terms of a 24/7 or 12 hours a day rate. I believe that IHSS, which is you have to qualify on needs basis.
What is IHSS?
In-home supportive services.
Okay.
Which is a government agency, and it's a needs-based agency. They provide assisted living waivers and assistance with a caregiver for very minimal care in the home. And I think they do 4 to 6 hours a day, not more than that. But most people coming home from the hospital need 12 hours a day or 24/7 a day, 24/7 care. And the government does not provide a path for paying for that.
So what I'm getting from what you're saying, we need to have a plan in place before you need it.
Exactly. That's what I started the conversation with, is that this is all about planning ahead, just like we have been talking about planning ahead for death, benefits and making transition. We need to plan for living now and how we can improve quality of life and prevent further decline. once a patient, I'm sure all of you doctors will attest to this, and what doctors have told me is once a patient falls for the first time, that starts a series of decline. That starts the path of decline because, and then the more you fall, the more you decline because the more you're susceptible to something having happened that is going to be a problem for you to address. So we want to prevent falls. And so the reason that we have a caregiver in the home, particularly after surgery, is to prevent a fall and we're there to reduce hospital readmission. So those are the two main reasons: reducing hospital readmission and preventing falls and or further decline. So we want to bring in someone who can help with those activities of daily living, help the person thrive and engage with them all in a safe and effective and compassionate manner so that we keep the hospital admissions lower and therefore not overwhelming the hospital system and not being causing more burnout amongst family members who are struggling to manage this on their own. It's very hard to manage a full-time job and take care of mom and do shifts between brothers and sisters, going over, et cetera. So we have to figure out how to make caregivers more accessible and affordable for everyone, not just those who have the means. Caregiving 24/7 is about $275,000 a year. So who does that immediately tell you can afford it? And who does that immediately tell you can't afford it? So therein lies the problem. And if 70% of Americans are going to need a caregiver and for an average of 3 years, then we really have some work to do to make sure that we can get everyone to have quality care.
And one of the things that
Access.
even as Dr. Walks and Dr. Hines have other questions that may be in the chat, there's something called long-term care insurance that I think ought to be addressed to our group. And it's only available if you buy it before a certain age, I think.
Well, you can buy it. I don't know if they absolutely have a cutoff, but it would be very, very exorbitant.
Yeah.
It would,
Yeah.
it would be exorbitant and cost prohibitive. Maybe for some it would be cost prohibitive, for others not so much maybe, but I've been told that the sweet spot, when it starts getting too expensive, you want to get it by 53, 55. Obviously before that and definitely by that time. And then after that, the cost do climb exponentially.
So
But
Dr. Walks is still eligible.
I love you, Dr. Maxey, but you
And I didn't know about long-term care insurance until I started working in caregiving, and that was 5.5 years ago. I'd never heard of long-term care insurance, but I also had not worked for a company that had a union, and in a union as an actor, but having a union is a big way to give access to individuals for long-term care insurance. CalPERS and LAUSD, they've provided long-term care insurance plans for their employees over the years. But what I've learned and what we've seen in trying to activate some of these plans or getting some people to get them, they're not available anymore. And a lot of insurance companies stopped offering them because they didn't expect us to live this long and really need to activate them and implement them. So we've run into that. Oh, it's not any good anymore, or it's going to cost more. And you want to just make sure that you get it if you are 55 and younger, or anytime in that time frame. But finding a good company where you can get one that's affordable, I think it's definitely worth it. And I'm glad that I got it. You just don't know what's going to happen, and you want to have it just in case.
Can you just speak to some of the things that long-term care insurance covers versus doesn't cover? Because I think that's also a space of confusion for a lot of people.
Yes,
about what their Medicare is going to coverage versus like long-term care insurance, that kind of thing.
Mm-hmm. Thank you. Great question. You have to meet 2 pillars of 6 pillars to activate your long-term care insurance plan. So you can buy it. Anyone can buy it. It's private. You're paying for it yourself. And then unless your company got it for you, which that doesn't exist anymore from what I understand. But when you buy it and then you're ready to use it, say you've had a surgery and you're a senior and you need some help at home now, and now you need a caregiver to come in. So you call the insurance company, you say, I want to activate my plan. You will have either anywhere from a 30 to 60 to 90-day elimination period first for you to pay out of pocket for your care. I don't know, it just seems so unconscionable to me because it's still quite expensive. So you would be paying for that depending on what that elimination period is from your long-term care insurance company, but then it does kick in. So this is really helpful for bedbound and homebound people who really have a declined quality of life because yes, they would need it ongoing and 24/7. So once you activate the insurance, the long-term care plan, they are going to ask you questions on the phone, specifically if you meet 2 of the 6 pillars, and those are the activities of daily living. So if you need assistance with, as I said, what caregiving provides, bathing, grooming, walking, toileting, and if you meet 2 out of those 6, then you are eligible to activate the plan, which it seems like, why would you even have to meet that eligibility? You've been paying for this plan, but that is how it works. And then they will bring, they'll pay, it's a reimbursement plan. So you pay and then they reimburse you.
Thank you for that clarification. One of the reasons that I brought it up is because lots of people make the mistake of thinking that activities of daily living should be covered by their like medical insurance, right? But it is not considered a needing help with bathing, even fundamental aspects of life are not covered by your medical insurance.
Not at all. And I've gone over this with families, many times and just, well, can you just call to make sure? And I just, to please them, I do it, but it's just not something that is done right now, which would be a benefit. I did, when I first entered into this space, I did hear from a utilization manager at Kaiser that Medicare was in the process of strategizing on how to create a type of support or supplement to the hourly rate of caregiving to give their Medicare members some support there. So for example, at the time, the rate was $30 an hour. She said, so for example, they would pay $15 and the family would pay $15 out of that $30 an hour rate. But that hasn't happened yet. It's 5 years later, and we still have not heard that Medicare is offering to supplement or cover caregiving that's out of pocket in full. Now, as we know, they do cover home health, which we'll get into that. But this caregiving piece is critical because I keep going back to the number of people that are going to need it as per the Department of Health and Human Services. But we're growing in California specifically at such a high rate. The geriatric population is exploding, not just because of the baby boomers, but and even after that. So we've got about 17 more years of baby boomer attention and developing a way to address this successfully.
Very interesting. Is there anything in the chat we need to deal with, Dr. Walks?
Yes, I see something in there. I don't know.
There was an article. There was a question in the chat about a link between Benadryl and Alzheimer's dementia. I think where our focus is more on the structure of caregiving and on the structure of let me say something that just has jumped into my head as we've been doing this, Ms. Johnson. We spend so much time on the Black Health Trust, and I can speak on behalf of some of the doctors. We spend a lot of time talking about the individual patient that's in front of us and how can we make you healthier? How can we? And your conversation is so much more complex because you're talking about the family and the folks who are connected to that individual patient. So while we're busy prescribing medication for heart and kidneys and lungs and other things, people who love the individual that we're caring for aren't really talked to about this aspect of family or this aspect of caring for a loved one. So I really wanted you to, and we'll have one of the really smart doctor people, scientist people talk about Alzheimer's and Benadryl. But before you go away, you mentioned a living trust. You mentioned us being able to have conversations before things are all in our face. Can you go back to exactly what a living trust is and why it's different to put your great aunt's home in a living trust as opposed to just, oh, well, when she passes, we'll work that out?
Oh my goodness, because the state will take it. You'll be in probate and that's that. But the truer answer is the living trust protects the assets from the state and from taxes. And if it was at that time, if the property was 600,000 and under, then I wouldn't have had to pay any capital gains tax on it, and I just inherit it free and clear. If you have nothing in place, then you put yourself at risk to have squabbles and infights with family members coming up out of the woodwork and the state at the same time. And even though, you know, we can't take it with us, if you can create generational wealth and create a plan to help your family when you leave with assets that you do have, that's, I think, a smarter path to take. Also, and I wanted to jump into a couple of different areas that you just touched upon, Dr. Walks. The asset can be used to provide care. We see a lot of families sell the home to get the financial resources to be able to either put their loved one in a senior living community, a quality senior living community, and they can live off of that, or downsize into an apartment or a smaller home and use the resources that way. So you've got an asset, use it for your best interest. Just don't let the state take it, or, you know, it end up, you know, tied up in court for you. So that's one of the main benefits of having the living trust, which I'm grateful that my aunt told me that she wanted me to have the home, and I came out to put it in a living trust to make sure that it was protected and I wouldn't have to pay taxes on it. So that was one of the big pieces. But from a caregiver, care manager, caregiving agency perspective, we provide resources. So if a family said, well, I don't know who to talk to, where do I go to begin that process? We have relationships. Again, remember, I was saying I build relationships so that we can get care started for whatever a senior citizen may need as they are aging in place. So we have fiduciaries, we have elder law attorneys, we have estate planning attorneys. We order the durable medical equipment for the patient. We have relationships with the hospital staff, of course, the case managers and social workers. In my home health agency that I work for, Epic Home Health, we have a medical social worker who can provide that level of assessment and understanding what the baseline is and what the human daily activities and needs are of that individual. And then we'll put in place and recommend to the nurse, these are some other resources that they need to help them thrive. So being very resource heavy is a critical part of care giving and care management. And having a care manager is also another resource. You can have a caregiver who provides that activities of daily living help, and they're the ones who are hired to be in your home with you. And then you have a care manager overseeing that process, making sure your doctor's appointments are in order and checking in with the family so the family can have respite. That is a huge part of the purpose of caregiving, is to give the family members respite and help and reduce hospital readmission and keep that individual safe in their home, preventing falls and further decline. So I hope I answered your question about the long-term, about the living trust.
No, it does, and I think that you mentioned two things. One is folks aren't always aware that there is something they need to do, such as the living trust, and then sometimes aren't aware of, well, how do I get that done? I heard those words, living trust. I don't know what that means. I don't have the resources maybe to hire an attorney or even ask an attorney about it. And so it's important to, one, introduce the topic and have the conversation, and then be able to help folks know how to access the resources to get something done. So thank you. Yes.
And you're welcome. And that's part of the assessment that the care manager will make when they go to the home to do an assessment and create a care plan. Those are the questions that they ask in terms of what is the family dynamic, who lives here also, who is the decision maker for your health, who is your POA, do you have oh gosh, the document is escaping me, but we do it all the time. The pink document that tells you if you want. Yes, advanced directive. Thank you so much. If you have that in place and signed, is it on the refrigerator where everybody can see what your wishes are? Should something happen? There is a complete assessment tool that is implemented when the care manager goes to the home to assess for what is going on and how to create a care plan. And that includes a safety assessment. Are pathways clean? Do you have shower grab bars? Do you have a higher seat for your toilet? Is your shower step-in too high? Does it need to be lowered? So we have a contracting company that we work with, and they can come and modify your shower entrance. Of course, ramps, we work with those companies. So we are supposed to be the last stop and provide all the resources that you need. And I think if you're paying what you're paying, that should be part of the benefit.
So a question just came to my mind, Ms. Johnson. Maybe in the near future, you and one or two members of your team could give us a whole session on what specifically we need to do about advanced directives, care directives, your legal team and whatnot. I'd like to see that so I can be of help to Dr. Walks. By the way, Dr. Walks is a renowned psychiatrist, former medical director of the health for the city of Washington, D.C. Dr. Hines is a family practitioner and head of the Maryland State Family Practice Association. And Dr. Barbara Neighbor-Stevens is a famed pediatrician from Nashville, Tennessee, who does a lot of work internationally. So, and then our audience is not just from Los Angeles and California, but we're all over. We stream live on Facebook and also YouTube. So you'll have a good audience. And the things that you have spoken today are just the tip of the iceberg.
Yes, yes, indeed. I wanted to, go ahead.
No, go ahead. I want you to come back. I mean, say more today, but specifically, how do we get to a home health agency for help?
Well, you can call the home health agency that I work for. I'm very privileged to work with Epic Home Health because they have not only this, we have not only the skilled team members, but we have the ethic and moral components and value system in place that I think are missing in a lot of company choices that you can make. I'll just put it that way. And it makes it a privilege to partner with a family-owned company like Epic Home Health, who believes in bringing effective, safe, and compassionate care to every patient that we care for. And whatever we can't do, we will find the resource that you need and put that in place and make that connection for you. And that's something that I actually take great pleasure in because it's a big part of my role as the director of marketing. And then I also bring my compassion and my passion about seniors anyway, my personal passion, to the role. I let the hospital know that I can come and talk to the patient at their bedside to explain what home health is and what you can expect, because a lot of patients have anxiety about it and will resist the care. And what does that do? That puts them at risk for declining or falling and going back to the hospital. So whatever we can do to help make the path a smoother path through education and compassion, that is what I am committed to doing. And that's what Epic does. We've been in business 24 years. So I think that says a lot. And we have a 5-star quality rating on Medicare.gov. So you start by calling Epic Home Health. And I want to just tell you briefly what home health is. It's the medical and skilled nursing services that are provided to a patient in their home. And that is the Medicare qualification. You have to be a homebound person, and that means you need assistance with leaving your home. And so we provide skilled nursing services for wound care, catheter care, G-tube, any infusion therapy, diabetic and nutrition care, medication management, anything that is needed, foot care. And then of course we have the medical social worker, and we order all the durable medical equipment and connect you with resources that you need that are beyond the scope of just the medical services in the home. And that's all covered by Medicare. Mm-hmm.
So Ms. Johnson, thank you so much. A couple of things that I wanted, well, 3 things. And the last one is that Dr. Richard Williams is on, and he waved his hand a little bit ago. So I think that he may have some comments that he wants to make. And I'm glad he wasn't here right at the beginning when we said all those wonderful things about him, because he didn't need to do all that. But in all seriousness, you mentioned a couple of things quickly in passing, I think that I just wanted to hit on. One, you mentioned POA, which I think you were using in the context of power of attorney. It's important to know who in your life you are going to trust to care for you and to make care decisions for you, which is why Dr. Maxey will not be in charge of my stuff. So when you mention POA, I think it's very. I would be blessed to have Dr. Maxey, but POA is something that it's important to kind of know who is in your life. And the other thing you said very quickly was having the information about what you want on the refrigerator. I recently talked with someone several days ago who had a challenge at home, and before anyone knew what was going on, the 911 had been called, the person had been intubated, and they specifically did not want that kind of put a tube down my throat and breathe for me, keeping them alive. But that wasn't, as you said, stuck on the refrigerator where everyone could know this is what I want. So I just wanted to hit those two things quickly and then defer to our wonderful Dr. Richard Williams, who I know had a comment.
Yes, thank you for those questions. I do want to expound on that. The power of attorney is the individual that you have entrusted to make decisions for you in your health and maybe your finances too, but specifically as it relates to us, it is the healthcare decisions. So the caregiving agency, the home health agency, they are going to only talk to the power of attorney. It doesn't matter what other relative, how close they are to you or what have you. When we are making decisions regarding your care plan, we are only going to, by law, be able to speak with the power of attorney. So, that's something that we can explain with gentility, has to be the process, but that is what we will adhere to. The advanced directive, having it on the refrigerator is the best thing to do so that it's a centralized location that most people will know is easy to find information. And so that's kind of a universally accepted place to place it. Obviously, sometimes people might have it in a binder next to the phone or something, but we're in a different time. People don't really have landlines to put things next to on the telephone table. But with respect to that information in the advanced directive, we want to know, do you want all bells and whistles if something does happen, or do you not wish to have all bells and whistles? This is part of the assessment when we come in to create the plan of care. That's why I said that's part of what has to be established at the beginning so that we know your wishes in case anything happens. It's critically important, and it's incumbent upon families to respect those decisions and work with us to help implement the care that the individual wants. And we want everyone to understand it is from a whole family approach. We are supporting you as a family with this dynamic that is happening. It's not easy, it's daunting. You have no idea, what's going on most of the time, or who to go to, what to ask, why this is happening. We just want to give you peace of mind and walk the journey with you in the most compassionate way, respecting the wishes of the individual that we are charged with caring for. I hope that helps clarify some of the question you had around that.
Great. Are there any
Yes, it does.
questions
Thank
from
you.
our audience?
Pardon me, Dr. Maxey?
I was wondering if there are any questions in the chat from any of our non-physician audience?
I think Angela is waving her hand. There were
And we
two
wanted
comments
Dr.
in the
Wi-
chat.
and
One is
we wanted Dr. Williams as well. And
we
instead of
did. I thought you were going to rush right past Dr. Williams.
and
I was afraid.
I think he'd appreciate, instead of using the word wonderful, let's put the word esteemed.
I
Dr.
don't think Dr. Williams really cares about wonderful and esteemed. I just think he is happy to be on the team and part of the family.
Amen.
Dr. Richard Williams.
Thank you very much, and hello, everyone.
Hello, Dr. Williams.
Hi, Mary Alice. There was a famous jazz musician who reached the age of 100, and one of his friends came to him as he lay there in his disabled state. He was quite ill at that time, and said, "Well, what do you think about the fact that you were able to reach this milestone, this age milestone?" He said, "Well, I'm not too happy to be ill at the time that I've reached this milestone." And he specifically said, "If I had known I was going to live this long, I would have taken better care of myself." well, it's an important thing to consider in regards to longevity and what we get into, so to speak, as we strive to live as long as we can. And I'd like just to open up maybe a little discussion on the longevity aspects and what we're getting ourselves into as people live longer and longer. You know, it's getting to the point where the aged population is going to exceed the younger population in our society. And that's a real paradox, mainly because of the fact that all those old people, I don't include myself among them, have to be taken care of. And I specifically wanted to ask Ms. Johnson if she could elaborate a little bit more on what seems to have become a healthcare disparity regarding people's ability to get on to, let's say, long-term care programs. That's a big elephant in the room in regards to how poor people and disadvantaged people can pay for something like that. Is the federal government going to finally come forth with some miraculous financial cure, so to speak, for our long-term needs? Are they going to step up to the plate and tax Medicare a bit more and provide long-term care as a part of Medicare, et cetera? Could you address that issue in particular?
Yes, thank you, Richard, for the question. Just a little bit, because there isn't a specific plan in place yet. In fact, our medical social worker told me that that's a huge part of why we have a lot of the healthcare disparities, because there is not, and I mean disparities in terms of how the doctor takes seriously certain diagnoses, and now I'm kind of going into the Alzheimer's piece, because there are huge healthcare disparities in that space. But the doctors are not, some doctors are not taking it seriously, or not have a centralized way to communicate between the general practitioner and the specialist. And so people are getting dropped, sort of left by the wayside, and diagnoses are getting, conditions are worsening because they're not getting the specialized attention that they need. So, and that always affects people with less means, less access, more. So it's, according to the Department of Health and Human Services, it says millions of adults and people with disabilities would not be able to live in their communities without essential support, and replacing it with paid services would cost an estimated $470 billion each year. So what is the government doing beyond in-home supportive services, which is the program that this one is referring to? I am not aware of anything at this time, but it is something that we continue to investigate and try to stay aware of, because as I shared earlier, I was told 5 years ago that they were going to start paying for caregiving and supplementing caregiving, and that hasn't happened yet. Meanwhile, lost income due to family caregiving is estimated at $522 billion a year. So there's a gap there, there's a need there, and if we can continue to utilize our political representatives to raise awareness and educate the community and galvanize an initiative, then I think that's the path that we have to stay on. But there's nothing specific that is rolling out that is meant to reduce the cost or cover the cost or even supplement at this time, so that people can have more access and to greater care and access to the diagnosis that they need to prevent further decline. And I wish there was, but this is what we're getting right now, which is not a concrete plan from the government, other than what they're supplementing through providing through IHSS, in-home supportive services. And then, of course, if a person is on disability, they have their SSI and SSDI benefits, which we're all familiar with, but something that is specifically for caregiving to cover it, not as yet.
Well, thank you, Ms. Johnson.
Richard, does that answer some of your question or give you?
It addressed the question, but
yeah,
I think that we need to pursue potential answers to that question through, for instance, the Black Health Trust. And if there's anyone who can suggest how we could move towards something that will really be meaningful to people who are listening in, to try to at least prod the government to
Yes.
get rid of this healthcare disparity, then I think that needs to be addressed on this program.
So Dr. Williams, I think you're exactly on point. Before you came on, I asked Ms. Johnson if in the future she could help curate a program with attorneys and another small group of how we could develop ways and plans that could help people. But it occurs to me, when I was young, I remember younger, I remember every few weeks, an insurance man would come by. At that time, it was Metropolitan Insurance, and he
Yes.
collect a small sum, $2 or $3 or something. So you never had a policy lapse because he was always at your front door. And if we did something like that aimed at our young people, our sons and daughters who are in their 20s and 30s and 40s, we might, for the next generation, be able to have long-term insurance, living trust in place, and greater sophistication in their ability to mechanically take care of people in Dr. Williams and Dr. Walks, I'm excluding Dr. Hines' age, in the future. So I think you're right on point, Richard. We need to address that disparity.
However, Randall, I think if you take a look at the numerics that would be involved from the standpoint of the money that would be necessary to finance any meaningful program of that sort, poor people simply would not be able to pay the kind of premium that would be necessary to sustain any kind of meaningful long-term care program. And so we need to have some probably governmental type of program instituted. I don't know how, as Mary Alice mentioned, how that would be done, but I can't see any other way around that. I don't think that it's going to happen through private means.
Well, I think you're right to some degree, but in reality, we should be talking about reparations for 400 years of slavery that put us in that position. But
Yep.
I think that's beyond the scope of what we have today. But we can start off by maybe even consulting a guy named Van Johnson, who just got $100 million to look at things like this. But we should put our heads together, along with you, Dr. Williams. You're famous at establishing a lot of big things. But we're almost at the top of the hour and make sure we get maximum utility out of Ms. Johnson while she's here. But we should
Please,
definitely
yes.
address what you're saying.
There was another question after Richard's, right? Or
Yes.
please.
Dr. Hines, who was Dr. Walks?
It was Angela. It was Angela.
Angela?
Hi. Can you hear me?
Yeah, is that Angela
Hello.
Moore?
Hi, sweetie. How are you?
Good. I just want to attest to Mary Alice's passion for the elderly. I work with her. We have some patients under her company. She goes out. We had a patient that was actually didn't go home as we thought, and she literally went to the rehab place to bring the patient food and make sure that the patient had her room, her place of living. They were talking about closing, not letting her come back to live there. Mary Alice and her team went there and talked to those people, to Miss Mitchell, to make sure that the elderly lady maintained her living space. That's called going above and beyond.
Yep.
And that's who Mary Alice is. And I'm witness to it. And it's not just that one patient that she's done things for. So she is passionate and dedicated and just a wonderful, beautiful soul of a human being that I love working with.
That's
So-
nice.
Thank you, Angela.
Thank you, Angela.
It's the truth.
Okay.
It's the
I see Dr. Sherrod's hand.
The same for Angela and double. Thank you, my sister.
truth. You're welcome.
I saw Dr. Sherrod's hand up.
Yeah, thank you, Dr.
You just went on to mute, Dr. Sherrod.
Unmute. Okay, here
There
we
you
go.
go. Go ahead.
Thank you so much, Ms. Johnson, for elucidating this subject matter. I have to admit that I missed part of it because my internet went out for a minute there. But I can go back and listen. But what I've heard so far, I agree that we need to institute and try to eradicate the disparity. But I have some specific questions for you. Are you statewide, your agency? Because I'm actually dealing with a situation in another state with a relative of mine, an elderly person who's become debilitated and is very unhappy with his power of attorney and everything. And I was just wondering if you give advice to people out of the state of California, or are you just localized to the state of California? And then the second question is, do you have a website, and could you leave your information as to contact information in the chat, or so that we can, because I would like to consult with you as soon as possible. This is such a big issue for our community. And I agree that we should actually have another program, Dr. Maxim, maybe even a side committee working on what we can do to try to eradicate the disparity. It's major.
It is. It is.
I'm gonna, Dr. Sherrod, thank you for those two questions. I just put the website for Epic Home Care and my email in the chat. Your
Okay.
first question, are we national? Epic Home Care is only in Los Angeles. We only have one office. And as I said earlier, it's been in business 24 years. It's a family-owned business. But I, being someone who will try to move heaven and earth to get you connected to resources that you need, I'm happy to talk with you to understand where your loved one is, and then what resources I can connect them with based on the relationships I have here, because my relationships here know people all over, right? So, and we, partner with each other to connect our patients or loved ones or clients with out-of-state resources. So I'd be happy to talk with you about that offline.
Oh, fantastic. Thank you so much. That's very good.
And
You're
one of
welcome.
the things I like to bring up, since especially Dr. Williams, who's the past president of the National Medical Association, I've never in all of my years heard this topic discussed at the NMA. We definitely ought to put this on our agenda with our current new president. And we're going to have on next Sunday the newly elected president-elect of the NMA, Dr. Virginia King. But we need to put this on their agenda. They have a much bigger platform than we do, because this definitely needs to be addressed.
Dr.
I
Maxey,
agree.
it needs to be addressed because it's not a question of if, it's a question of when. This is happening right now. And I don't know how people are dealing with it. I can only imagine the increased level of stress and depression and anxiety, because here's the thing, if you can't take care of your loved one, you're already going to feel guilty. You're going to have to maintain your job, and then you may lose your job. We talked about the amount of money lost due to lost income because people are electing to stay with their loved one, because yeah, we all want to be able to take care of our loved one, but it's just not sustainable over time at the rate at which we are aging. Does that make sense?
Yes.
Yeah.
So may I share my screen and just show you one graph about how quickly we're aging that Dr. Taylor has given me and uses in the presentations that we do really quickly, Dr. Maxey?
Go ahead.
See if I can get it.
And tell us who Dr. Taylor is.
Yes, Dr. Gregory L. Taylor is the founder of the Signature Care program at USC Keck Medicine. He's an internist and a geriatrician. And the Signature Care program at USC Keck Medicine is their concierge care. And he is also the founder of a biotechnology startup that I am privileged to be involved in. And it is called Biomed. And the purpose of Biomed is to help address the need for precision and personalized dosing in hemp-derived cannabis therapy. And Dr. Taylor is just an extraordinary humanitarian and physician. I don't know why I often have trouble doing this, so just bear with me. I know where it is, but I just need a second. So let's see if I can do it this way.
Tamara, does she need the ability to share her slide?
It's set up.
No, okay, here, share. Oh, there it is. Okay. Hold on one sec. Can everyone see this?
Yes.
Okay. So the map of the percentage increase of elderly population aged over 60 and over between years 2010 and 2060, you can see how California is just lit up down here, right? Southern California, where we are. So in LA, 150 to 199% between the years of 2010 and 2060 for the age 60 and over. This is LA right here, 150 to 199%. The map of the percentage increase of the elderly population age 85 and over in years 2010 to 2060. Los Angeles, over 400%.
Wow.
Hmm.
Oof.
So this is, it has to be dealt with. And as Richard was saying about healthcare disparities, that takes us into a whole other area, because what percentage of this 400% are those who cannot afford to have options that we've been discussing that are so costly? And what do we do about that? We can train family members, we can pay family members to be caregivers. We can elect to stop growing in our own career development and goals and stay home. And that's usually women. It's always the daughter, 9 times out of 10, that is taking care of the loved one, right? So that means women will not be advancing professionally, and that impacts the workplace and the economy. So the costs to not address this are myriad, and we really need to get on it. And I know that, you know, politically is definitely a very strong way to do that. And doing things like Dr. Richard Allen Williams has done and Dr. Randall Maxey have done.
Well, we thank you so much, Ms. Johnson. We're at the top of our hour, a little bit past. I'd like you to have some final thoughts, and then our moderators.
Did you say my final thoughts, sir?
Mm-hmm.
Thank you
Well,
so much.
Dr. Maxey, did you see Dr. Lawson's hand over here? I think you
I'm
probably
sorry,
missed.
Dr. Lawson, I'm sorry.
Yeah,
Maybe-
Dr. Lawson has his hand up before you close out. He usually has.
Dr. Lawson,
Request.
other esteemed
Yes.
psychiatrist.
Yeah. Okay. Never
Hi,
mind.
Dr. Lawson. How are you?
Absolutely doing well. And I don't know if you know, I'm now the president of the senior psychiatrists. And one of the issues we're going to raise at the next APA meeting is ageism, which interacts racism and sexism to lead to a big problem in terms of not only the disparities, but also lack of access to treatment and also lack of focus in terms of developing those political resources to deal with these issues. And we're trying to work with Doctors for America, see if we can get some of the medications available for us. And I'd like to see if you have anything to say about rural individuals. I'm from a rural community originally, and one of the things that's happened is that a lot of folks are going back to the South and going back home. And what they're finding is that is often they go back, find their friends are not there, that the resources just aren't there. I had to argue with a neurologist. I said, yeah, we have treatments for things like Alzheimer's. And he had not a clue as to what I was talking about. So, and when we start doing like advanced directives and so forth, that's like talking about extra planetary events. That information is often simply not available in many of our southern states where many of our African-American people are returning.
Wow.
That is a huge and very important side topic to this whole thing to unpack, because, and I haven't had any experience with working with the rural population only because I'm here in LA. So I can't speak to it in depth, but I know that one of the reasons that people are going home is because of the expense of living in bigger cities and they're downsizing. And then they're going home because they have family and support, right? But that support, again, if they're working, they're going to run into the same problem that we're talking about now. How do you balance working your full-time job and taking care of a loved one? Same questions will come up. What resources are there? what do you understand about the process? And equally important to all of this is what healthcare professionals are in your life that are truly invested in helping to create a plan of care that allows you to thrive. What healthcare professionals really care, that are paying attention and taking it seriously. I had a whole subject about the racism in Alzheimer's that we can touch upon in another talk, but Black people are dying at a higher rate because of not, as you just said, Dr. Lawson, not having the access to the care and not being taken seriously about symptoms that are reported. That's absolutely appalling and absurd and needs to be eradicated. So, oh, I'm sorry. Again, you're really passionate.
It's all right.
I'm so done with not caring about every individual and the discrimination and the racism and everything. It's 2023 and it just shouldn't be. There's such a spiritual disconnect, and we need to educate everyone, the families, the physicians. This is now. The future is now, as Dr. Taylor says. The future of healthcare is now, and we cannot continue to die at rates like this just because of the color of someone's skin or where they live and not giving them access. So yeah, how do we figure it out?
If Attorney Anthony Maxey can unmute, he had a recent experience of taking care of older relatives. I'd just like him to speak about a second if he is still there and can unmute.
I did, thank you. Ms. Johnson, your presentation was fantastic. I went through that. Yes, the cost is what you said it is. Number one, with Alzheimer's, getting it diagnosed. My older sister had it, but the doctor, in my opinion, when I went back, should have told me something. He should have also told my other sister what was going on. I went back for a visit, and at that point, my whole life changed because I had to bring her here. Then I had to go through finding a caregiver, finding the proper medical, all of these things, which I didn't know, and that's not what I do for a living. So it is very time consuming. And yes, you cannot take care of a family relative and work full time. No way. I tried it. No way. There should be some cost or some benefit giving to people to help them with this cost. My other sister was a senior, luckily not with Alzheimer's, but she had the
IHSS, yeah.
And they offer barely 4 hours a day. Now,
yeah, that's what I was saying.
Your patient is cognizant, they can sort of look out for themselves, which my other sister was. But that doesn't mean a lot because she still needed assistance at certain other times. And she needed someone to come in there and cook for her and so forth. And I had to supplement all of that, especially on because they only give you a maximum of like maybe 20 hours. If that,
right,
that's nothing.
Right.
They walk in there. So yes, everything that everyone has said is very, very true, especially with Alzheimer's. The doctor did not diagnose it to me. My older sister took the testing for Alzheimer's, and even I saw it. Do you know who told me my older sister had Alzheimer's? Was the person who repaired the roof on our house when I went back. He said, Mr. Maxey, you are dealing with what I dealt with my mom. He said, just leave it. We can work things out. And then I started taking a closer look at it. And then I brought her here. But yes, there's a big disparity in the healthcare and so forth, and in the prescriptions that you get. If had my older sister been diagnosed sooner, I think she would have fared better with it. But
exactly.
Well, thank you.
And that's what we're talking about, improving the quality of life, meeting people where they are and getting them all of the right care and resources.
I think there's another person, there's Dr. Carolyn Teague, who's a psychologist. Dr. Teague, do you have a comment? Can she be unmuted?
Hello, Dr. Maxey.
Hello, Dr. Teague.
I do not have a comment right now.
Okay.
Thank you.
Well, Ms. Mary Alice Johnson, we certainly appreciate what you brought to the Black Health Trust today and opened up an entire number of things that we have to deal with. Let's go with our final comments, Dr. Hines and then Dr. Walks.
Yes, thank you again, Ms. Johnson, for this topic. And like you said, you know, the information on having the discussions early and taking the proper steps in preparedness. I look forward to our teacher discussions. One of the things that we didn't touch on was around like how technology can support folks kind of in the aging in place space. There are a lot of things available now that can help people stay in their homes. And especially if you're trying to do like long distance kind of caregiving and those kinds of things. I did put in the chat the executive order that the Biden-Harris administration recently put out in regards to, they're in the early stages of making initiatives towards investigating the caregiver space, and they're coming at it from kind of the sandwich generation approach. And the sandwich generation approach is that space that recognizes that a lot of people are caring for children as well as, you know, elders in their life, while also trying to navigate, you know, work and all the rest of those things as well. So I just wanted to put that out there. And
Thank you
again
for that, Dr. Hines. And I had heard of that, and thank you for giving me that correction, because I did hear of that, but I hadn't heard any updates on it. But that's so good that you put that there. Thank you so much.
Thank you. Dr. Walks?
Thank you, Dr. Maxey. Ms. Johnson, thank you so much. This has been very, very useful. There's something about doctors and others looking at just that interaction. And so I mentioned earlier about this whole doctor-patient thing, and they're people that are our patients. And these people have all the same challenges that aren't part of our expertise. I really appreciate Attorney Maxey being on and talking. I think one of the things he said was, that's not my area. That so many different kinds of expertise need to impact a person's life. I just said to someone last week, if everyone was a doctor, who would fix my car? I mean, that we have to recognize the importance of all of the different ways that we can impact a person's life. And so much of what you talked about today just really, really matters as we want to effectively love the people that are in our lives. This is so important. And to Dr. Maxey, I thank you for broadening the Black Health Trust to allow us to really have these kinds of conversations. And for my last little comment, Dr. Maxey, I will say, Dr. Williams, you really missed a lot of really good stuff said about you at the beginning, man. These people really like you. So I always tease Dr. Williams. He's one of my heroes. And I just really love it whenever I get a chance to get at him. So thank you. Thank you all for everything. Go ahead, Dr. Maxey.
Again, I want to echo a lot of thoughts about what you brought to the table, Ms. Mary Alice Johnson. You're a wonderful person. Your topic is wonderful. And we invite you back. We'd love to have you. Thank you so much for this valuable information. We'll be here again next week.
Dr. Maxey.
Yes.
If I may, I would be remiss if I didn't thank Richard, because it's because of Richard that I connected with you and am able to share the experience that I have in healthcare overall, between caregiving and care management and home health, with the public, which is what is incumbent upon all of us. We are here to serve God by serving each other, I believe, with all my heart. And that's where we need to get connected. There's such a spiritual disconnect in understanding why we're here and what to do to help each other. And I'm grateful that Richard has connected me with you all, so I can do my part to share my gifts and talents to help uplift the world. So thank you.
And thank you so much. And Richard I give him credit as being my professor, my teacher, and my hat's always off to him. I wrote 2 prescriptions this morning for Paxlovid. So it's on the way back. And I mean COVID-19. It may be a different strain. May be more invasive and pathologic. And our guest speaker next week is Dr. Virginia Kane, who was just elected as president-elect of the National Medical Association. She is the medical director of Indianapolis for their public health department, and she's a world-class expert. And she will be with us next week. Thank you, everybody. Thanks for joining us. Enjoy the rest of your day. Thank you, Simon, for your immense help.
Thank
Good
you,
day, everyone.
everyone. Thank you, Dr. Maxey, so much for having me as your guest. I'm so honored, and I will love to come back.
Thank you.
Thank you. Be well, everyone.